Hello, we're going to take a few moments and let everybody join the webinar, and then we will get started. Okay, we've got people coming in. Still steadily rising, the numbers.
Good.
Okay. All right, welcome to TMA's Empowerment Clinic, Living with Dermatomyositis, Making It Easier. I'm your host, Rachel Bromley. I am TMA Senior Manager of Patient Education, Support, and Advocacy. And today we have two guest panelists with us. We have Dr. Julie Paik and TMA community member Shauna Nielsen, and I will bring them up and let them each introduce themselves briefly. Dr. Paik, you can start first.
Yes, hi, my name is Julie Paik, and it's so nice to be here. I've been at Hopkins for, I was trying to remember, for about almost 13 years. I'm actually originally a Californian, like Shauna, and I came to Baltimore, Maryland for fellowship because of my husband. And then I stayed on faculty here after I finished fellowship. And my official title is Associate Professor of Medicine in the Division of Rheumatology. And I am the Director of Clinical Trials at the Johns Hopkins Myositis Center. And I also work at the Hopkins Scleroderma Center. And my research focus is primarily in overlap myositis and also in therapeutics, novel therapeutics, clinical trials in myositis as well. Thank you for coming.
Awesome. Thank you so much. Go ahead, Shauna.
Hi, I'm Shauna Nielsen. I'm an RN and a dermatomyositis patient for many years. I'm co-leader of the Northern California Myositis Support Group, and we have online Zoom meetings about every other month. And I'm working on some other projects with TMA and looking forward to the both online and in-person conference in San Diego in September.
Oh, thanks for the plug. Okay, Dr. Paik is going to share a few slides and talk for a little bit. And then I just want you in the audience to know this is going to be more of a conversation. For the first time, I'm going to open the phone lines, as it were. If you want to talk about your journey very briefly, or if you have a question, you can raise your hand at the bottom of your screen. It says raise hand, and I will make it possible for you to speak. So let's go ahead and you can go ahead and share your screen. Dr. Paik, are you on mute?
Yes. Is this sharing? Do you see the whole?
It is sharing. We can see it. Yeah.
Okay. So I think I may have already given this talk to the TMA group, but it's really, I wanted to highlight updates in the myositis space for trials, because it's in a very exciting time in myositis. I think if you ask any kind of academic specialist right now, there is a plethora of trials compared to like vasculitis or lupus. I don't think we could ever reach like RA per se, but for myositis, it's a huge amount of trials that are coming down the pipeline. So I'm going to highlight just basic things because I'm not 100% sure about our audience here. But
yes, you did the myositis research webinar in January, and that is available on YouTube in its entirety. It's there already on our channel. But yeah, feel free to highlight a few things from that.
Yes. So dermatomyositis is a rare autoimmune disease in the kind of hub of idiopathic inflammatory myopathies, or what we call myositis. And one of the subgroups of myositis is dermatomyositis. It affects women more than men, 2-to-1 ratio. And the prevalence, it ranges, but it's pretty rare. I mean, it's more rare than, ALS or Lou Gehrig's disease. It's about 50 to 100 per 100,000 for prevalence. And in comparison to other subgroups of myositis, like inclusion body myositis or necrotizing myositis, dermatomyositis tends to have a very distinct clinical presentation with the rash, as you can see here, over the knuckles, which we call Gotrin, named after Dr. Gotrin, who was a dermatologist a long time ago in Germany. And then the heliotrope rash here is purple with over the heliotrope flower, named after the purple petals of the flower. And the rash can actually be whole body. So I've seen patients where the skin is so severe that from the waiting room, you can spot her because it's what we call whole body erythroderma, where it's head to toe redness. It looks like you just had whole body sunburn. And then you also can get rash on the thigh. And so especially our new patients and, all of our patients, we try to get them in a gown and examine their whole skin. And this is called the Holster sign. And it can be over the knees. And, this is a picture of a muscle biopsy. And we always have this discussion, do we really need to do one? I would say as a rheumatologist, it's going out of favor because it's so obvious, like with a skin exam or a skin biopsy if you need, like from the thigh or, the arm, to make this diagnosis because it's very distinct pathological findings on the skin biopsy. And then another very interesting aspect in the diagnosis of autoimmune diseases, including lupus or rheumatoid arthritis, vasculitis, scleroderma, are that, and one of the main reasons that a lot of rheumatologists get excited about getting into rheumatology as a specialty is that we have different blood tests that we can use to identify whether a patient has an autoimmune disease. And in fact, I think in myositis, it's quite specific and prognostic and very helpful in getting a full clinical picture of a patient. So for example, I mean, there's a lot of kind of circles here, but for dermatomyositis, there are these myositis-specific autoantibodies like MD5, MI2, SAE, and there's a group of anti-synthetase antibodies where you can get skin and lung disease. And then these two are associated with cancer, but not everybody gets cancer. NXP2 is also associated with calcinosis, where you can get calcium deposits in dermatomyositis. I'm not going to talk about calcinosis that much today because, actually there's no good treatment for it. But for calcinosis, it's very challenging. But one thing to remember for calcinosis is that it can be debulked, like removed, and then you want to really be aggressive about treating it early on to avoid the deposition of calcinosis if it's possible. And then we have those overlap myositis. You can see all these things that I have in circles. These are autoantibodies. And these are myositis-associated autoantibodies because it's associated with, instead of myositis-specific autoantibody, MSA versus MAA, because these autoantibodies are actually associated with like a different connective tissue disease, such as scleroderma, lupus, Sjogren's, and things like this, for example, like Rowe or Law. Here's IMNM. What is that? It's immune-mediated necrotizing myositis. It's another subgroup of myositis. Because the main four subgroups, are dermatomyositis, necrotizing myositis, inclusion body myositis, and polymyositis, which is really diagnosis of exclusion. So there's two autoantibodies that are associated with necrotizing. But for today's, briefing, it's really, we want to focus on these that are associated with dermatomyositis. And the beauty of treating and diagnosing dermatomyositis, I always say, I always tell my fellows and trainees and my patients is that I could just diagnose somebody based on looking at their hands. And, the kissing papules you can see here. And why is it called kissing papules? Because it's right here at that crease. And so if you bend it over, it's like kissing each other. And this is the palm of the hand. You can see these commonly and can be quite painful. And this is associated with MD5. And then this ovoid palatal patch, if you look in the mouth, and this has been described by Dr. Fiorentino, a famous dermatologist at Stanford who studies dermatomyositis. In terms of the treatment paradigm, I've used this slide, you might have seen this in the prior talk that I've done, but I probably have to, I like it. I still, that hasn't changed at all since 1994, unfortunately. And that's why I'm so excited about the multiple clinical trials that are coming down the pipeline. But here, we usually use steroids and use one of these 3 agents as first line, kind of standard of care. But there's no head-to-head study like in rheumatoid arthritis. You compare TNF inhibitors to methotrexate or different TNFs and all these things. We do not have the luxury of that. We're a disease that is a very orphan disease. So we don't have that many patients. But if someone has, skin like dermatomyositis with muscle and joints, methotrexate tends to be our first line. And if someone has lung disease, azathioprine or mycophenolate tend to be first line. And we also do use a lot of combination therapies. So we do add IVIG for dysphagia or even rituximab if someone has concomitant rheumatoid arthritis. And now, as of July 2021, the ProDerm trial, slide is actually, now it's been published in the New England Journal of Medicine. But as of July 2021, IVIG, which we've been using since 1993 because of Dr. Delakias, actually, he's the originator of using IVIG in dermatomyositis. Because of this study, though, it finally led the FDA approval for IVIG. So it is much easier to get. And I think this will allow more patients to access it in a more universal way. And then because we're talking about dermatomyositis specifically, rituximab, while it was a negative study back in 2013, when they look at the post hoc analyses, meaning they had close to 200 patients, I believe, in the study, if you take out the people who responded, or you take out, so you're doing post hoc analyses after the study's done, completely and fully analyzed. It was a negative study, but you go back and get the patients who did have a response and had dermatomyositis. You can actually see that these patients who had those Gottrin papules I showed you on the pictures, they had improvement by 24 to 28 weeks. The percentage of patients had improvement. So we do use rituximab for dermatomyositis. And there's a lot of data coming out in a recent systematic analysis that rituximab works really well in patients who have autoantibodies, which was another post hoc analysis of the rituximab and myositis trial from 2013. But that's more than 8 to 12 different clinical trials using rituximab in different countries have shown that rituximab does work, but it's still not FDA approved, unfortunately. So hopefully that will change. And then this is a busy slide, but I just want to highlight one thing here in yellow. There was a phase 2 clinical trial using an anti-interferon beta, which is directly targeting a molecule that we think is very, very important in the inflammation involved in dermatomyositis. And it's a drug that was made by Pfizer, and it's an infusion drug. The phase 2 looked a bit promising, I believe, because now the company is trying to go into phase 3. So that is one of the pipeline drugs that to be looked out for. And then another drug that has an ongoing clinical trial right now that I was more directly involved in is that was actually really inspired by my patient, where she had failed everything, and we tried TOA Sittin, a JAK inhibitor. Initially FDA approved by FDA approved. I think now it's like 2013 or no wait 2012 maybe by Pfizer, or even earlier for RA. Actually used it in dermatomyositis. And she had a really good response, and it led to this study, the STIR study. And our endpoint was at week 12, and patients had a really good response. And you can see this is her baseline skin, and this had significantly improved. Even all the neck involvement had improved. And we did pre and post muscle MRIs in our patients in the study, and the edema improved here. The white means there's inflammation that was gone by week 12. And then we even did up to week 96, which is more than, it was like close to 2 years, right? Of using the drug, and patients had a good response. You can see this is completely gone. This is just a little bit telangiectatic lesions. which are kind of what we say damaged from having disease for a long time. So because of this, there's this phase 3 trial now, and of another JAK inhibitor, and this one I think the interferon will come. The other Pfizer study that I was mentioning, the anti-interferon beta, and the complement inhibitors. There's an ongoing clinical trial now for Alexion, which is a complement inhibitor, ribolizumab. We've enrolled several patients in that study, and now it's moving on to phase 3. And then other treatments to kind of give you an overview. I think this is my last slide. Other treatments in myositis. You know, I put PM and DM together here only because some of these trials actually included both PM and DM. So like the RIM trial told you was a phase 3, it was the largest one led by Chet Otis at University of Pittsburgh and Rohit Agrawal at University of Pittsburgh with a negative study. Belimumab was recent in 2 years ago. It was at a conference, the data was presented. And I don't think the paper is actually published yet, but will be coming out. It was a negative study, which is another kind of B-cell inhibitor. But it was a very, again, these 2 studies, they included only refractory patients, meaning you had to fail 2 agents. You had to so I think there's, you know, that I could go into a whole reverie of why the clinical trial design is so important in our patients. Anyway, so these were negative studies. Abatacept is a T-cell agent, and that was positive in phase 2. So we were very promising, but phase 3 was negative. And these are 2 new phase 2 trials, and these are kind of like IVIG, but works in a similar way. They're called FcRn inhibitors, and those are coming out in the pipeline right now. And the brepocitinib is the JAK inhibitor phase 3. This one is coming out very shortly, I'm hoping, from Pfizer. And IL-23 is ustekinumab, which you might hear from, oh, that sounds familiar, from psoriasis. So there is a phase 3 trial going on right now, only in Japan. I have some colleagues in Japan who have hopefully will inform us about the final results of this. And the tocilizumab phase 2 was negative. So anyways, I think those are the conclusions. You know, treatment is really driven by organ manifestations. And the first FDA-approved drug finally is IVIG. And there's many really promising treatments in myositis. So I hope that was 15 minutes or less.
That was perfect. Thank you so much. I have a quick question. You showed that one slide with PM and DM together. Did they include both of them in the trial because the subtypes are so similar? Because I'm not aware of how similar those 2 are.
Yes. Though PM and DM, they're very different. But
Okay.
the reason why they're included together in these trials is because I think to increase the numbers, and when you look at the outcome measure that they use, the outcome measure is for polymyositis and dermatomyositis. But like I said, if you ask any myositis expert, including myself, you'll be like, oh, polymyositis doesn't even exist. But the problem is some countries and some places can't even test for autoantibodies. And so, you know, it kind of gets into more like semantics and other kind of more research studies. But bottom line is they did include, these 2 trials definitely included both. But when you think about PM, I really want you to think that it's really a diagnosis of exclusion. And now, because these trials, phase 3, and this trial was also, it took a really long time to recruit. I know Galina Martyr, who was the PI on that study at Northwell, and she said it took a really long time to recruit. But now, like these trials, you can have PM, but if you don't have an autoantibody, you cannot qualify and enter in the trial. So things are really changing in terms of understanding the different subgroups of myositis, and that polymyositis is really like a diagnosis of exclusion. You need to have an autoantibody to say you have polymyositis, because most of those polymyositis diagnoses in the past, if you were diagnosed in 90s, early 2000s, or any in the past, whenever, if you didn't get autoantibody testing and someone called you polymyositis, you better be sure that you really have the diagnosis based on a biopsy, autoantibody that supports that you have it, or it may be that you have an immune-mediated necrotizing myopathy, or even, I have a lot of patients who come to us and they're like, I've tried everything for my polymyositis, but it's actually inclusion body myositis. So you have to rebiopsy, or you don't even have to rebiopsy. If they saved your biopsy slides, but most hospitals only save it for 10 years, unless you went to an academic center where they save it forever. Like at Hopkins, we have biopsy slides from 1990, no, we could bring it up like 1978 if we wanted. But in that sense, we're very blessed and privileged here. But if you don't want to repeat the biopsy, then you can have someone look at it again to make sure that they look for those kind of rimmed vacuoles that you would see with inclusion body myositis. So yes,
thank
so going
you.
back, yes, I hope that answered the question.
It did. Thank you so much. Okay, you can stop sharing. And
Oh, okay. Yeah.
all right, let's see. Shauna, you are up. Let me add your spotlight. All right. Let me add my spotlight. We can have a conversation.
Yeah,
There we go. Hi, how are you?
I'm great. Good to see you today.
Yeah, okay. Well, I've got a few questions for you. You're so inspirational to me. You really keep a positive mindset despite your chronic illness. You're still active, you volunteer, you have your hobbies that you've adapted. It's just a beautiful thing watching your journey. So tell me a little bit about your journey.
So I have had dermatomyositis for about 27 years. The first 14 years were intermittent rashes, and I was about 7 or 8 years into that 14. So it took me 7 years to get a diagnosis, and I had multiple skin biopsies to come to the diagnosis of dermatomyositis. And it remained skin only for another 5 to 7 years. At some point, I looked it up. I'm a nurse. I didn't want to know too much about it. I went, oh, some people only have skin. And I closed the laptop and never looked back. But I went skiing at about that 14-year mark with my family. And I went from skiing to couch potato in about 10 days. Still was not thinking this was the dermatomyositis. I only thought I had dermatositis. And it took me a week or so. And my friend said, you're not doing anything. And I got to the doctor, got some testing, and then it dawned on me, maybe this is the myo part of dermatomyositis. And indeed, I did have the myo part. It hit hard and fast. I got down to 30 steps a day. My dermatologist, who had diagnosed me midway through the skin only, quickly got me to a local rheumatologist, who then recommended I get to a specialty center. He was happy to help me, but he doesn't know enough about myositis. So that took about 3 months to get in, and I went to Stanford to the doctor that Julie talked about, Dr. David Fiorentino. I learned quickly that participating in the decision-making, so learning as much as I can. I found TMA, I mined the website, I got on the chat groups at TMA, which were active before we came into this new social media world with Facebook and Instagram and that kind of stuff. So I was on the TMA support line for a while. And I learned to participate in making the decisions. I did as much research as I could. I wrote out my history and went in to see the specialty doctor. And then my goal was to treat it aggressively, and I'm doing well, I think, because of that.
What would you say DM's biggest challenges are for you?
Well, I think the first challenge for all of us is to accept that our body is fighting against ourselves. And then you have to make a lot of decisions. So for me, I had small, middle-aged children, a marriage, and I couldn't walk. I could think, I could talk, I could chat online, but I couldn't walk or do physical things. And I had to make a decision at that point. And I came up with a mantra that was, this is my chance to show my children that there is a reasonable way to handle adversity. This was horrible adversity. There were years where I was stuck, not able to do very much. But I sought out the best experts. I learned as much as I can. I got on a plane and went to the first TMA conference. Physical therapy, physical therapy, physical therapy. And that I learned at my first conference was that even though in the past doctors told us to rest because our blood work looks like we just ran a marathon, and you want marathon runners to rest after their big race. that physical therapy was better for us than sitting still, which had been the old style. And it was at one of the conferences that a doctor from Sweden came and described that her military men did better. And so she did a study that showed that exercise was potentially very, very good for us. So I didn't ever stop moving. The other challenge was getting my local close family to understand the variability. So some days I could make dinner. And some days if I went to physical therapy, I couldn't make dinner. So there were lots of days where I would put food in the crock pot, go to physical therapy, and lay on the couch the rest of the day. So, and other days I could do things. And to get a family to understand that was challenging. But they did. They came along.
What myositis topics are you most passionate about?
I think for me, the first is definitely advocacy and helping others to not struggle in the way that is common with myositis. People commonly, it takes 7 to 8 years to get diagnosed. So I am passionate about helping to educate others using the science. So I have 2 Facebook groups that I administer. I'm active with TMA, going to the conferences, the support groups, and then the video vault on TMA is amazing. I prefer it to going to Instagram. If you go to TMA into the library, then into presentations, you will get the scientific information from the doctor's video talks in succession. So the newest information is at the top. If you go down 5 years, you know that's 5-year-old information. So I really like it that way, as opposed to just going on YouTube and searching. It's hard to know when those were produced. So you might not be getting the most up-to-date information. I'm passionate about the cancer fears and the IVIG, SCIG. So we can get immune globulin now sooner, like Julie said. The study just came out. It's FDA approved and European Union approved as a first-line treatment. So I waited 2 years to start IVIG, and others now can get it much more quickly. That's what turned the table for me. So I like to educate about IVIG. As an RN, I have given IVIG to patients. It takes some finesse. The doctor orders it, it goes to specialty pharmacists who get it to you, and then you have a nurse either in a center or at home, but running it slowly enough, hydrating enough, using some pre-meds. What do you do if you have challenges? I'm really good at helping navigate that world. So those are the things I think are most interesting to me. And I give support to people every day online. I like keeping my mind active. So that's what I'm most passionate about, is helping others not suffer the same way.
How do you still find joy in your life despite having DM?
I think that's hard for some people. For me, I sort of keep the DM, and I have an autoimmune disease that's known to everyone, but I keep the details kind of to myself. If someone says, hey, can we go out for brunch at noon in the blazing sun at an outdoor patio? I don't ask them to understand my disease. I say, hey, I could do noon inside, or I could do earlier on the patio if there's shade. I just change the things. Yes, I could host Thanksgiving, but it's got to be potluck and I may have to retire early, but you're welcome to come use my space. So I don't ask my family to understand. Even as a nurse, I couldn't understand this disease if a patient came to me. But so I don't ask them to understand. I ask them to respect my limits and work with me. Oh, that doesn't work for me. Could we do a movie next week instead? Something in the dark. We still travel. You know, if we go to the beach, we try and stay on the water in a house where I have shade protection. I still walk every day, but I walk early or late. I use my sun protective clothing. This is a sun protective perio. I've got a whole host of hats. And then I changed my interest. So I hike and I take bird photography because that's easier than skiing. I'm still out in the outdoors. I love being outside. I find shaded trails if I need to go in the middle of the day. And then slowly, I might go just 2 benches. Then I went 3 benches. Then I could do 4 benches over time. It took me probably 1.5 years to be able to walk 2 miles. And I enjoyed where I was. And so I kept doing it. And that's what they'll say. The kind of activity you want is something that you can maintain 5 days a week. If it's too much, it'll set you back and then you won't want to do it again. So it takes determination, but boy, I wanted to be active again. And then getting the right meds from your doctor and having a team.
Yeah, that's my next question,
Yeah.
because we've had conversations before about this. What is your advice on building a healthcare team?
I think dedicating yourself to looking into the doctors, finding one that's actually interested in autoimmune type diseases with rheumatology, who might have an interest in skin and muscle diseases. It can be dermatologist, rheumatologist, neurologist. In your neighborhood, there's going to be someone who knows the most, and that's who you want to see. Not so much what their name is, but who knows the most. Then are they willing to connect with specialists? So I was at my local doctor, then I went to Stanford and bring the information back with me, and they communicate. My local doctor plans things, orders my labs, sends me for all the work that needs to be done, all the testing. But the specialty clinic helps us decide where we go next. If I have a flare, what do we try? So the team for me works well. When I vet a new doctor, I often call and ask the office if I can talk to the back office. And I have 3 questions I want to know. Does this doctor like puzzles? How often do they communicate with other specialty doctors? Do you have to bother them in the room to talk to someone important who called on the phone? And if they can't fix you, does that bother them for an hour, a week, or a month? Because I don't want the doctor that can't fix me and that stresses him out and doesn't want to see me next time. I want the doctor who goes, that's a puzzle. So I take paperwork with me all about all the things that have happened in my life, my allergies, what we've
You
tried.
keep a book or a binder of.
I take a binder, but when I couldn't walk well, it came in a rolling suitcase with me because I couldn't walk it. I used a scooter at times to get into the hospital with all of the documents. I bring everything with me with copies, because if that specialty doctor, you get them for 90 minutes and they say, do you have a copy of that biopsy? And they take that form to go copy it, someone's going to bother them and you're not going to get them back in the room in the same mindset they were when they left. So I have sheet protectors and then free sheets, and I just throw them at the doctor. They don't have to leave the room. You can have everything I have. And then with a GP or a new doctor, if I need a GYN surgery, I go in and say, this is what I know about me. I have this autoimmune disease. I've had other surgeries. Are you willing to be part of my team? I've said the same thing with a dentist. Are you comfortable with the medicines I'm on treating me? If you're not, who's the next guy up the line that's better with complex medical patients that I can see? And I ask them to buy in to be part of my team. I don't expect them to fix me. My goal, and I'll share this with them, is I want you to help me get the most out of my life that I can from here. I know I have this. We're not going to fix it, but how do we maximize what I can do? Maximize the treatments to get me in the best shape with the least side effects. So,
Dr. Paik, I wanted to bring you in the conversation here because we, as a physician, what are your thoughts that Shauna is sharing about communication between you and your doctor, and then also expecting communication between your doctor and other specialists?
Yeah, I mean, that was just so inspirational. I mean, thank you for sharing your story, but like, that is like the A+ patient that we all wish to meet. But I think that communication, I have many patients who have a local rheumatologist and then also me. I like how you actually, maybe I don't want to admit it, but getting the attention, that focused attention by your specialist for that period of time, and then they leave the room to scan and all that stuff. Like, first of all, one thing to know about academic physicians is that we do not have a lot of support. We have to say this out loud. We do not have a lot of support. We do not have a nurse. It's not a fancy private practice, so we are scanning everything ourselves, copying things. So it is very nice when our patients are prepared and has, things for us like right there, then and there, or it's like, sent to us beforehand so we can look at it in the computer, which is nice now. Yeah.
right. I call ahead and see if they want it faxed or emailed. And then you want copies, because what if you get to that specialist and the power goes out?
Oh, I didn't think
lights,
about
but
that.
they're
That hopefully will never happen. There's
That's right.
generators at hospitals.
And if that biopsy does disappear, you need to have written down what it was at, so that
being
when,
ex-military,
if
I
your
know
doctors
that for
retire,
sure.
sometimes
Yeah.
that stuff just poof, the records
Mhm.
disappear.
Yeah.
So I'm
So the other thing is, I think it's good that our patients, it is very helpful to have, I always say, be your own advocate. If you don't hear back from us, like call again or send a message. Everybody is busy. Like we all know everyone is busy. It doesn't matter what you do or, who your family is or your friends. Everyone has their busy life. And so, be your own advocate. Don't expect. I think that's hard though, because we're giving you this diagnosis and it can be quite overwhelming for my patients.
Absolutely.
And so sometimes it takes a couple visits to kind of discuss that, because initial visit may be really just talking through and educating about the diagnosis.
Right.
And then it may take some time to really, try to remind them after they soak it in that they are the primary driver. I always say the dermatomyositis is in the car, you're driving, but it's in the back seat. You, me, Julie Pack, me, Sean and Neil, Rachel, I'm still in the driver's seat. You have control.
I say I'm the student driver on the bus and I bring everything to you and then take it back. So I do a lot of moving things. The other question.
Go ahead. Go ahead.
I had a thought and
I'll ask mine and then we'll come back to you. Dr. Pack, you said that Shauna seems like the ideal patient you would want to have. What is on the opposite spectrum of that? What can we avoid as patients to improve our care?
Yeah, no, I think having your history kind of laid out, and if you have an excellent memory, which I don't either, like I put stuff in my phone.
Not on steroids. Excellent memories go south on steroids. So having it written down. I keep a little calendar that's the size of a checkbook and it's 2 years. And they'll say, well, how much steroids were you on when you had that biopsy?
Yes.
I can flip through and tell them because I don't want to look them. So, but I have to have it written down.
Yeah. So I think having that history, like when your diagnosis, because for us, it's usually like second or third opinion when they come to us because we're like a tertiary referral center. So having those details written down or, in your phone or whatever it may be is very helpful when you're not prepared for the visit, and have questions written down. Like, I mean, obviously if it's 3 pages, that's like too much maybe, but like, at least, your 1 page of questions that you may have with your first visit or every visit is fine, because I try to go over those with the patient.
The other thing I like to do is next to my questions, what labs, then I'll write the answer. When do I see you again? 6 weeks. What do we do about this? Then I say, okay, before you go, normally there's 6 people in the room. There's interns, residents, physical therapists, social workers, nurses, doctors. Sometimes I get 2. I'll say, okay, wait a second. Before you go, let me review. I'm going to do these labs. I'm going to see you in this much time. If this side effect happens, I call you. Okay, wait a second. The last thing I want to know is, what do I do if there's an emergency? When would I go to the ER? And I'm really good with I'll email you about refills. I can wait a week for those. But if I have a crisis, how do I get in touch with you? Sometimes that's different in different practices.
That's true.
So the message that goes through someone to the nurse, to the doctor isn't always the best if you have a crisis. So then for me, with my team, they asked me to call the office and make sure someone puts that in front of them. And then they'll call me back. If I'm having a big flare, 4 days and I'm still going downhill, we'll adjust meds on the phone. So figuring that out, when do I go to the ER? And that's usually lung problems, heart problems, can't swallow, can't get up at all. So you were mobile and now you're bedbound. Those would be ER visits. But for most things, we want to contact our doctors and make a plan. These are chronic illnesses. They're not emergency illnesses. The ER really doesn't know how to help us much.
Right. Okay, we've got a question come in when it comes to fatigue, and I want Dr. Pack's input and then Shauna to also pipe in about it. They want to know if it could be a result of being heavily medicated on prednisone for a year. They started at 100 milligrams and then tapered down. They're currently at 50 milligrams. Or is chronic fatigue just a symptom of the disease, or are both contributing factors? How can you tell which one has caused it and what can be done to combat it?
Yeah. So I'll go first. Like, I think fatigue is prevalent in many autoimmune diseases. It is a initial manifestation of diseases, in autoimmune diseases. And certainly medications can also exacerbate it or really bring it out. So I think if she or he has been, I don't know if it was a he or she, but like been on prednisone for 100 milligrams for that long, I definitely think there can be major side effects from steroids that can contribute to fatigue. For example, of course, I'm going to take kind of a more of a medical kind of, perspective on this, but if someone's on steroids for that long, it can cause a lot of, steroid-induced muscle atrophy, which can cause a lot of weakness and fatigue. And you also want to make sure if you're on steroids for that long, your thyroid is okay. And there's no other reasons, for example, secondary diabetes that may be contributing to a lot of fatigue, things like this. In of itself, fatigue is not well studied as a predominant manifestation of specifically dermatomyositis, but it is well known that with flares or when the disease is raging, our patients really do have a lot of fatigue overall. But I think it's hard to study, but I do think there should be, better research studies in the future, because it is a very, big component of our patients who a big complaint, so to speak. From our patients.
Julie, have you heard at the last conference, there was a doctor from Australia who implicated, for the first time I'd heard at a conference, that mitochondria might be related to some of our fatigue as time goes on. And I know my pulmonologist recommended I use mitochondrial supplements while I was exercising, along with the creatine, to try and push myself and gain strength and energy. And the endurance comes last for me, but I was able to get precipitously stronger. It was probably 4 times longer than when I was healthy. I could train for a 5K in 3 weeks. Now it takes me 12, 16, 18 weeks to even get ready to train. But the mitochondrial supplements really did help support having energy when I needed it. I still needed some extra rest, but I didn't have that blinding fatigue feeling that I had before starting them.
I think the data is not robust in that. There may be some small studies highlighting that. So I wouldn't blanketly recommend it for all of our myositis patients. I mean, there's definitely more data on mitochondrial dysfunction and inclusion body myositis.
Right.
But when we do staining on muscle biopsy slides of dermatomyositis patients, or even immune-mediated necrotizing myositis, and there's a specific stain that we look for mitochondrial dysfunction, and it is more common, but no one has taken that to look at metabolic studies to see if those, mitochondrial dysfunction associates with fatigue on a questionnaire for our patients. So I think,
is there any
could work? Will it hurt? I don't think it'll hurt, but if it helps you, then I'm always supplement. As long as it doesn't hurt you, I'm okay. As long as you're not taking mushroom supplements that contribute to muscle disease and toxicity to your muscles, I'm okay.
Dr. Paik, we got another question in. With so many ongoing clinical trials, how do you recommend patients choose to join one over others?
That's a really good, excellent question, because right now we've been talking at our center with our director, Dr. Lisa Christopher-Stein. We have 7 or 8 trials. It's just been ridiculous around this time, but also there's actually a big demand. But anyway, going back to the question, it's really about the inclusion criteria and exclusion criteria for each trial. But when multiple are going on at the same time, I present all the different ones that are active, and these are the benefits of this drug and the cons and why you may not be a good candidate. For example, I was telling you about the JAK inhibitor medication that we studied, and now there's a phase 3 on that trial that's ongoing, active. But I remember we referred a patient and we were talking to her. There was another trial, the Alexion trial, revolutimab, which is a complement inhibitor, and the brepocitinib is a JAK inhibitor. And I feel the JAK would work better, but she's excluded because she had a clot in the past 3 years. So, your medical history is very important for that. So I think we always present it and just look at the inclusion and exclusion criteria to see which one would benefit the patient the most and not harm the patient, number one.
Right. But Dr. Paik, it does help if someone wants to be in a trial to get to one of the myositis centers to find out about all the ones because you may be in a regional area where you can't be there enough to do the trial.
Yes. And I think this is where the TMA and the Facebook group, they're so important to, I do a lot of consulting with companies, and they'll ask, well, how are we going to get these patients recruited? I'm like, you need to talk to the patient liaisons, the groups, TMA, MSU, Facebook, like, and so they know now, like, that's where they need to, engage in addition to coming to us, because it's, we can't as physicians do that kind of level of recruiting, I think.
Okay, we had another question come in. This person has been diagnosed with DM, but the myositis screen for autoantibodies was all negative. Do you see this often? And would you recommend rescreening after a period of time?
So for myositis autoantibodies, it depends on where it was done. There's a lot of false positives. And so there's probably like 8 different labs that do it in the US. And then if you ask in Japan, there's maybe only 1 or 2 labs. If you go to Poland, I just had a patient who came from Poland. She was from Poland. She goes back and forth from Poland. She's like, look at my autoantibodies. And it's like, everything's positive. So there's all these false positives. And then when I rechecked her here, it's all, only 1 was positive, something like this. So I think it depends if it was a reasonable lab that did it. And if that was a negative, then I would do a more comprehensive myositis panel. We tend to at Hopkins, and this doesn't mean it's the right answer, but tend to send it to the Oklahoma Medical Research Facility. It does take 2 months to come back, but they double check their work to make sure it's a true positive. And then, like, for example, at Stanford or at Hopkins, like us, we work with our translational scientists who also do it in the lab in a very rigorous way. Dr. Olivia Cassiola-Rosen, who leads our lab, RDRCC, the research core. And so we can double and triple check if we really need to, for myositis autoantibodies. But there are some companies that are awful, so you have to be careful, where it's sent.
Okay,
So yes, I would, if it's negative and she has symptoms, I would definitely recheck it. Yeah.
I've got a hot topic question that I know Shauna's going to love. I almost wonder if she had this planted.
No, I did not today. I'm usually the plant asking all the questions.
Right, you're on the camera, so you're not behind the scenes this time. Just wait till you hear this question. I was diagnosed a year ago and am convinced my DM was caused by the COVID vaccines. I had 3, all Moderna. Is there any proof or information that the COVID vaccine has caused DM? Do you know of patients who believe they got DM because of the vaccine?
I know
Let
of lots.
Julie go first.
Yeah, I bet Julie has
Let
more
the doctor
science.
go first.
I'm seeing it in the science.
You can go first. I have some, go ahead. I have some thoughts on this.
We're hearing a lot about it, and we're seeing some of the scientists in myositis report that they're seeing dermatomyositis more likely just sparked off. You might have had a propensity for it anyway, but it was laying underground, and that the vaccine and or the disease of COVID seems to be increasing symptoms to the point that people are seeking treatment and care.
Yeah.
We're also seeing patients that have myositis get COVID disease or the vaccine and have flares related to that. So they might have had myositis treated and stable, and then they go out of stable. Does that match with what you're seeing scientifically?
Yes. So I think the reason why I hesitate is we have to be extremely careful that we don't sound like anti-vaxxers here, because it's not the vaccine that caused your disease. Right. Now, there may be rare circumstances where that could have happened, but it's in the milieu of your genetic background, your family history, and all the epigenetic phenomenon of your body, of what you eat and everything else. I think the whole picture, and maybe that was a trigger, but that in of itself, all by itself, I think we have to be careful about saying that, because I do think the vaccine has saved many, many lives.
Absolutely.
And so I think we have to be careful how we say it. But yes, I've seen a lot of triggers of flares. I have seen patients who triggered and then they came as a new patient as dermatomyositis, but not so much as, I don't see as much the vaccine triggering dermatomyositis, but COVID definitely.
Absolutely.
Like really severe COVID, hospitalized, and then months later they come and they had dermatomyositis, or
Right.
scleroderma or rheumatoid arthritis, like definitely that I see.
Right. So we know historically that vaccines can spark off Guillain-Barré, chronic inflammatory demyelinating polyneuritis. So it's not out of the realm that vaccines can enhance viral things.
Like trigger
Most
maybe.
of the patients that come to my group, if I say, did they test for antibodies? Yes, they did right away. And I already had autoantibodies, which sort of seems to link towards it sparked it versus cause. You know, it's a shift of words, but I haven't heard anyone say I was totally well before. And no one in my family has ever had an autoimmune disease, that kind of person that said, you know, there's no reason why I would think it might be them.
So Dr. Paik, I think you are muted again.
Oh yeah, sorry, I was drinking.
That's
my soda
okay.
with ice.
So basically, it's possible that the vaccine could spark it, but getting COVID could also spark it,
Oh yeah.
is what you're saying. I mean,
Yeah,
you know,
it's
so
a
it's
trigger.
still your choice that you need to make with your physician, ultimately.
Absolutely.
So, okay, oh, that's another, I'm sorry. The other reason I hesitate, we led in one of the largest, I was very blessed to work with a phenomenal scientist, Joy Segev, who it was the transplant, he's a transplant scientist. He does all the transplant research at Johns Hopkins. Of course, then NYU recruited him. And when COVID started out, they had this huge national registry of patients of, oh gosh, I think it's the largest national registry. I mean, he came out on CNN, he came out on all the talk shows. So he was looking at what happens with COVID vaccine efficacy after transplant. And then I got involved as the lead with a fellow who's phenomenal, Dr. Quillen Connolly. We were both co-leads basically to look at patients who had rheumatic disease, RA, lupus, you know, and what happens to them when they get the vaccine. So there were two key questions we wanted answered, and the transplant data was telling us that some of that data already. So number one was what's the efficacy of COVID vaccines? No one knew this. Even the American College of Rheumatology said, you're on CellCept, get the vaccine. It doesn't matter, it's gonna work. The vaccine's gonna work. Nobody knew this, but it was already coming out in the transplant literature that if you are on CellCept or azathioprine, the vaccine does not work. Like you were not protected against COVID. And that was, the results came out of that based on a surrogate measure of COVID antibodies, antibodies to this specific area of COVID, the virus. So we looked at that in our patients with autoimmune diseases, and myositis patients were included, and it was the same answer that if you got your vaccine and you were on mycophenolate, then you probably did not have any response and you were not protected at all. So actually, I've had multiple patients who are on 3 grams of CellCept or mycophenolate, and they got COVID and got very sick, even though they were vaccinated because they thought they were protected. And we did further studies showing that there was a dose response. So if you're on low dose CellCept, you had a better antibody response or efficacy response than someone who were on high dose CellCept. So that was the first question. Second was, okay, so you get the vaccine, what happens? Do you get a flare of your disease? So the flare rates were probably, we looked at close to almost, I think it was 2,000 patients with autoimmune disease. And the flare rate was less than 10%. So very minimal risk of flare, similar to getting, shingles vaccine, right? And these are not live vaccines like yellow fever or measles, mumps, or rubella. So we thought it was very safe. Our study was the first to be published. And then there were multiple other studies that came out that showed that there were in lupus and RA, that there was really low risk of flare. However, it's not negligible. You certainly can get it. Now, I talked to Vicki Worth at the TMA conference. In her, subset of patients with just DM, she said she did see a signal for flare. So, it's very different. We didn't have only myositis patients. We had like RA, people with MS. We had RA, pemphigus, things like this.
Right. And I wanted to interject here that we just did and asked the doc with Dr. Worth, and she talked about her COVID related research. And so
Yeah.
that is on our YouTube channel. You
Oh,
can
good.
go and watch it and see what she had to say about it.
Yes, yes. Yeah. So anyway, bottom line is it's still safe to get. So I think, but anyway, that's a whole different topic. If you want,
I know we could
talk.
talk for a while about it.
Yeah.
We've got 5 minutes. Do you have a
Oh
hard
my gosh,
stop?
I'm so sorry.
Do you have a hard stop? Do you have to get off
me?
right at 7, Dr. Pack?
No, I think I could go to like 7:15. I just have to pick up
Okay.
my son from practice.
Yeah, we have three questions and I want to make sure that we get a chance to get to them. This person has scalp dermatomyositis that has not responded to treatment as well as the rest of their body.
Oh,
There wasn't a question. They just,
yes. That's
I
an
mean,
excellent
why
question.
would
One
that?
of them is, how do we deal with itch? It's challenging.
Yeah.
It's
Yeah.
very challenging, isn't it? We think there's different receptors, and I think there are people who have studied this in the scalp. And in fact, I have biopsied someone's scalp in a clinical trial. But yes, it was not responsive to with our drug. So I think the scalp is like a different beast, and it's even I think IVIG tends to work, but not everybody. So it's not uncommon someone's on IVIG and it does improve, but then we still have to do that foam, you know, the steroid foam and things like this. Yeah. It's very hard. Yeah.
A related question was, is there a way to numb the itch? Because that is the most difficult part of the scalp inflammation. So is that the steroid foam that you're talking about?
You can try that. And then for itch, I also use like Lyrica and all these other medications to stop with the kind of histamine release
The
involved.
stuff that
and the
works, is
pain.
it all prescription based or is there anything over the counter that's helpful?
I'm not aware of anything over the counter. No. But-
Okay. This person asked, have you noticed any trends?
So one thing,
sorry, go ahead.
going back to the scalp though, I had a patient who kept dyeing her hair, you know, and I have white hair that I dye too. It's very irritating. So I think for the scalp, using natural, I'm not saying don't dye it, but like, you know, natural and not bleaching. And she was bleaching too, I think.
Right.
And it definitely associated with it, like the
Right.
flare.
Hairdressers, if you tell them ahead of time, can get a barrier cream that sticks to your scalp that keeps some of the chemical off the skin, but you have to order it ahead, let them know. And then highlights work better because they can start a little bit further from the skin.
Oh, that's very good.
Yeah.
That's very good. Oh, I didn't know that. Learn something
Or
new.
you can just let your gray grow out like I do.
Yep.
Not when your kid's like, why do you have so much white hair?
So Dr. Pack, do you use any low dose naltrexone for itch?
I have not, but I know some people have.
Dr.
So-
Fiorentino is prescribing it now, which he didn't 12 years ago when I
interesting.
started seeing him, but
Okay.
he did
Yeah,
give
I
it
know
to
that
me.
some people do.
And some people like it.
Yeah, some people like
It's
it.
a
I
tiny,
think we should
tiny
do
dose of an
Yes.
narcotic med. So naltrexone is used for addicts, but we use little micro doses, and it can cause sleepiness. So some people use it for sleep, but it can help with itch and pain for some people.
Mhm. It's used for a lot of other. Like I said, I see patients in the scleroderma center also.
Mhm.
And so some of our patients use it for like motility issues, which is interesting.
Yeah.
So I think it's used. I do think it does help a certain subset of people.
Yeah, some people. It's sort of came from the functional medicine world, and it's
Yes.
sort of trickling down, and some of the doctors are using it.
Have you noticed any trends in symptom severity when DM overlaps with another autoimmune disease such as scleroderma?
Oh, I guess I'm a perfect person to answer that question because of my research interest in this myositis and scleroderma. So it depends on your perspective. I think when you're in the scleroderma center and you see patients with scleroderma and myositis, actually, and this is something that in the scleroderma experts, we talk about, like, if you have myositis, I can actually treat it with your scleroderma. That can actually is a good prognostic indicator that the muscle is very treatable. versus certain aspects of scleroderma may not be as treatable or quick to respond, like the skin tightening, if it's really, really tight, is not as quick to respond as the muscle, in my opinion. If you have, and so that's why this is a difficult question to answer, because it depends on the spectrum of where you lie. If you have more myositis, I feel like the scleroderma aspects, like with Raynaud's, where you get, vasospasm of the fingers and you can get gangrene, that could be very scary to a patient with myositis in general, because you're not really dealing with that. But I've had patients who had gangrene and had to get amputation because of severe Raynaud's with their myositis and scleroderma, of their finger. But I see that more in my scleroderma patients. So if someone has scleroderma in this other spectrum where it's more scleroderma with some myositis, the myositis seems actually much more manageable than how severe the scleroderma can cause renal failure or lung fibrosis and needing lung transplant and even more severe medications to immunosuppress. So it really depends on which facet or which organ we're talking about, even within the overlap syndromes. It's really hard to tease that out. And I think that's the challenge of kind of studying overlap myositis, is really need to break it down to which organ am I treating and how am I going to choose an agent that will help be the most efficacious for that organ, but also help the other organs that could potentially be involved in overlap syndrome. Yeah. I don't know if that makes sense, but yeah.
So, final question for you, Dr. Paik. What advice do you or would you give your patients as a general, how to make their lives easier living with this condition?
Oh, that's a difficult question. I think overall you want to remember that, I know it's hard to remember, but because, when you have a chronic disease, it can really be overwhelming sometimes. But just like I said before, it shouldn't control your life, even though in many ways it may feel like that. I really liked how Shauna said, like, you may feel like, oh, I have this awful disease, which is not, compared to some other autoimmune diseases, is much more treatable, fortunately, which is why I love myositis. But to take control and you make the priorities and you make the decisions, not that the disease leads you to.
All right, Shauna, do you have any final advice for words of wisdom for other people living with DM?
Yeah, I think especially early on, many of us are sort of type A. We want to do everything. And you have to learn where you can cut the corners. This isn't the year or two when you're trying to get this under control to be manic about keeping your house clean, or to avoid using the Instapot and crock pot and rice cooker that you can set and forget. Because participating in your family in a reduced way is still participating in your family. And figuring out what's going to work, what kind of help you need. There are apps, there's lots of helping hands, where I had to schedule all of my children's carpools because I couldn't drive for a while. And getting people to bring meals and help out in that short term over a couple of months until my husband and I got in the groove. I didn't want this disease to affect their lives, so I got the support I needed. It was harder for me to ask for support for me. But I have a few close friends that understand, and the rest of them, I just set my limits and say, oh, yeah, that doesn't work for me, but how about we do this?
I really like that, how you said that. That's like perfect,
Yeah.
In terms of like, when they ask you, well, what can I have lunch at this time? You're like, no, this actually works better for me.
Right.
The other thing in the treatment aspect, it always breaks my heart when I see my patients and they've had the disease for so long, and we could have made such a big impact if I saw them early in their disease. I could have potentially shut it off. Yeah. But because maybe, and it's not that the other doctors mismanaged it, it's just that the disease is so rare that even my friends who are rheumatologists, they have one myositis patient. So they just don't know how important it is. to treat aggressively and early. I think that's really important, and not just use one agent at a time. Like,
Right.
I had a patient one drug for 3 years, and they said this was the only drug, or like,
Right.
well, if you come to me that late and you have all this damage and fatty replacement in your muscles, it's so hard.
It's hard. I have another good question for the doctor. Maybe the second or third time you see the community doctor, I ask, how many patients do you have with myositis? I hope to hear over 10. But if I don't, the next question is, how many of them are back to a semblance of their normal life? Maybe a slower life, but you will find community doctors who think we need to be severely disabled for the rest of our life, and the only option is to be in a wheelchair.
Right.
And if my doctor has that belief that I'm so sick I can't have a colonoscopy at the endoscopy center, I have to go to the hospital, I walked in with a walker and oxygen, and the doctor said, you shouldn't be doing this well. And I went, ooh, you're off my list. I will find someone else. I need cheerleader doctors. I don't need doctors that think I'm going to be totally disabled for the rest of my life in my 40s. So fighting for that, finding that is key, I think, and treating early and aggressive. We have patients online that are scared to death to try any of the medicines. And I try and remind them, when you look at methotrexate, the side effects talk about cancer doses, not our little micro doses we're using.
Right.
And we're watching you closely, but please don't be afraid to try. I waited 4 years to try methotrexate, burned out the other ones. They didn't work for me. And when I tried it, I got stronger, more endurance. It's my favorite treatment. I would give up IVIG if I could keep that methotrexate, because it just, and I waited 4 years. I was scared to death of it. So I say, try.
And I think that the fear drives a lot of us in many aspects of our lives, including myself. But I think building that team, like you said, from the beginning, and having that rapport with and the trust with that physician, so you can openly say, like, I'm really scared to try it. Tell me, how many patients have you treated with this? What do they look like? Are they in remission? Those are really key questions. And when my patient asks me that, can you get me to remission? That I can honestly answer yes, but you need to work with me.
Right.
You need to work with me. If you don't want to, it's, it's hard.
So that's a good, Plaquenil is a good example. People are afraid to try it. They have to get eye checks. But in front of the 23 physician TMA board at the conference, everyone says, have you seen anyone with eye complications or go blind from hydrochloroquine? And they'll say, Plaquenil, hydrochloroquine, same drug, different names. They'll say, no, we've never seen it. Some people need to go off it, but we've never seen severe complications. And if patients don't know that and they're too afraid to try, they may miss out on an option to have less itching and less skin symptoms.
Yeah. Yeah, Plaquenil, though, I mean, I think because we see more severe manifestations, it's really only for mild disease, extremely mild disease. So I don't really have that many patients on it. But I do agree with you that when
but we see patients that are afraid to try anything, which is an example of afraid to try anything.
Yeah. But most of my patients are actually, they come, I think, because they want options. Yeah. And I think it's always good to have a lot of options. I don't know how everyone feels, but
yeah. All right. Well, thank you both so much for being here. We really appreciate the time. And we've enjoyed talking to you, and we hope to see more, both of you, soon.
Sounds great.
Looking forward to it. See you at the conference.
Oh yeah, see you at the conference.
Right.
Yeah.
And thank you to the audience. I'm sorry, go ahead.
Oh no, I said I'm excited. It's gonna be San Diego, right?
Yeah. Oh, yeah, it's going to be fun. And I am pushing for a COVID session so we can all argue about it.
Oh, I don't know.
You're like, maybe not. Maybe
well,
we're not ready for that.
Did the government say that COVID's over in May, which is not, but you know what I mean?
Right. Let's just pretend it is. We're good.
All right.
All right, thank
so
you
much.
to the audience for being part of our webinar tonight. Be sure to join us next month, April 17th, at 1 p.m. We will have our first international Ask the Doc, Dr. Malin Regart, and the topic will be occupational therapy. So we're very excited about that. You can join us next month for that. For TMA, I'm Rachel Bromley. Good night.